Good evening, my friends, and welcome to another episode of NMAI TV. I hope you had a wonderful summer. Now we're back, and today we're going to talk about artificial intelligence. The definition of artificial intelligence is the theory and development of computer systems able to perform tasks that normally require human intelligence, such as visual perception, speech recognition, decision-making, translation between languages. This is affecting many parts of our lives, medical practices, health, work settings. I currently use artificial intelligence on my phone. I have an app, a ChatGPT-4 app that I use, and it helps me in different things to get information on any topic, assist with preparing documents, protocols. It's almost like a virtual assistant. It costs about $10 to $20 a month to use this. About 23% of Americans have used ChatGPT, and that's growing every year significantly. Today, we're going to take a deeper dive into AI in terms of what is it, how it works, the mathematics behind it, new advances in ophthalmology and eye care for AI for both physicians and for patients, including the pros and the cons. Before we get started, I do want to acknowledge my co-moderator, Aaron Dotson, who's normally here with me, but cannot be here today to help moderate because he's doing his cornea fellowship and studying for his boards. I just want to give a shout out to you. We look forward to you to conquering these next milestones and coming back onto NMAI TV. And I also will acknowledge our new NMA Ophthalmology Section Chair, Dr. Basil Williams. Congratulations on taking on the torch, and we look forward to working with you and hearing great things from you as well. Now, we have two special guests I'll be introducing shortly. But before we begin, please like and share the video. Please give us a thumbs up for the algorithm. Please type questions in the chat, and we will drop a live link at the end for live questions and answers. Make sure you keep your camera on when you come on live, and then we'll get started now, okay? Our first presenter is Dr. Stephen Odaibo. He is the CEO and founder of Retina AI Health. He is a physician, retina specialist, computer scientist, full-stack AI engineer, and an AI ML expert. Dr. Odaibo completed his undergraduate in mathematics at the University of Alabama School of Medicine and the University of Alabama and medical school at Duke University, where he won the Barry Hurwitz Award for Excellence in Neurology. He completed his ophthalmology residency at Howard University and retina fellowship at the University of Michigan. In addition to his medical training, he holds master's degrees in both mathematics and computer science. In 2017, UAB College of Arts and Sciences awarded him the college's highest honor, the UAB Distinguished Alumni Achievement Award. Dr. Odaibo has authored 3 mathematics textbooks, Quantum Mechanics and the MRI Machine in 2012, The Form of Finite Groups, a course of finite group theory in 2016, and most recently, The Foundational Mathematics of Artificial Intelligence in 2024. In 2019, Dr. Odaibo chaired the Artificial Intelligence and Tech and Medicine Symposium at the National Medical Association meeting. He serves on the advisory board of the Duke University Master's in Engineering Program and Artificial Intelligence program. Dr. Odaibo chaired the Medical Device Software Development Summits in the United States 2022 and 2024 and European Union 2023 and led AI workshops in all those meetings. He is a Google Cloud Certified Professional Cloud Cybersecurity Engineer, and he will chair the 2024 Cybersecurity for Medical Device Summit. As a retina physician, Dr. Odaibo also continues to provide excellent care to his patients. So we are very privileged to have Dr. Odaibo join us. Due to a conflict of interest, he's not able to appear live during this moment, but he has submitted a video for us for his presentation, and I will just turn it over to Dr. Odaibo and his video presentation to us. Please show the video. Can you show the video, Brother Reggie?
I'll be with you in a second.
Truly an honor and a delight to be here at the National Medical Association Ophthalmology ITV. And today's topic, artificial intelligence, what is it? What's the math behind it? Is a topic that's near and dear to my heart. I'm an ophthalmologist myself, and I've been involved with the NMA for several years, all the way dating back to my medical school days at Duke School of Medicine, where I was president of the Student National Medical Association. And through residency and fellowship and the Rab Venable program, the NMA has been a key part of my career. And so it's really a delight to be here to talk about this topic. I've been working in AI for quite some time. So my undergraduate degree was in math, and then I did a master's in math and a master's in computer science. And from before AI was a buzzword, I've been working, and it's just been fascinating to see all the developments. So my goal today is really to, in very simple terms, explain what the basics are about what AI is and how it's developed. From financial disclosures perspective, I'm a first inventor on a couple of intellectual property patents and US patents, and also a sponsor investigator with Retina AI Health Incorporated, which is a startup that I founded in 2017. And but in terms of this topic today, it's purely educational, and so there are no financial interests. I'm not talking about any particular products that we have developed or are working on. So this is the general outline that I'm going to follow. What is artificial intelligence? I'll just give some examples of that. We've been seeing so much of this, and it truly is a remarkable technology that is revolutionizing all industries. And I'll just give a little bit of taste with some examples of generative AI. And then I will say a little bit about how AI is developed, in particular with regards to what neural networks are. That's the unit module of AI systems. And then a little bit about how AI is changing healthcare, then a slight view towards the future and what we can expect. So what is AI? In my view, any algorithm that has learned from data and can now use that knowledge to perform certain specific tasks, right? An example might be if there's, say, data on chest x-rays and you train a neural network, an AI algorithm, to recognize certain nodules as malignant or non-malignant or suspicious or non-suspicious, a very specific task. And once it's learned from the data, your AI can then be deployed for diagnostic purposes. That is an example of an AI system. I want to put a plug for a book that I wrote earlier this year in April, and you can get this on Amazon. If you're really interested in the details, this talk I'm giving here, I don't go into any particular details or equations or anything of that sort, but this is a 400-page book titled The Foundational Mathematics of Artificial Intelligence, and we really cover everything from A to Z from a very detailed mathematical perspective on that. So that's something that's available to people that might want to hear more about this. All right, so what I'm showing here is a picture it looks quite remarkable. You know, where did this come from? This is an astronaut that's floating on a cloud, right? And generative AI has reached a point today where you can really just think of anything in your head and go ahead and just say it. And this is from OpenAI's website, and you can try this out on your own. And these are still figures. And so whatever you can think of, we're at the point where you can really just write it out, like floated in space, an astronaut lounges on a couch that's shaped like a cloud, and it comes to life right before your eyes. And we're also now at the point where with things such as Sora, that software of generative AI technology, you can actually make videos. And people are now projecting, and it's not unreasonable, that probably within a couple of years from now, one would be able to make an entire feature film. AI technology is something that we're looking at it clearly from a medical perspective, from, in particular, ophthalmological perspective, but the math and the code and the algorithms behind these things are the same, regardless of what application or what industry it's been deployed in. And so one very important thing is to understand the full capacity of the technology, and then one's eyes can then be very clearly open to all the enormous potentials and opportunity that actually exist within our field of ophthalmology. All right, so this is another example that they put up, and you can read the prompt yourself. It's a photo showcasing a camera crafted with corals and jellyfish immersed in. This, for instance, is something that never previously existed. Somebody thought it up in their head, prompted it, the machine, and boom, within seconds, it is materialized. This is another one. Very impressive, very detailed. These are art examples. In this case, a photo of a middle-aged Polynesian surfer with sun-kissed skin, struggling to surf, etc., etc. He is holding a massive, overwhelming pile of 50 objects, teacup, bicycle, umbrella, etc. And within seconds, this picture is brought to life, something that previously never existed. You're really just telling this to the computer, a trained algorithm, and it's able to do this. And I assure you, if you actually counted how many objects were on this thing, I would not be surprised if it's exactly 50. So that's how advanced this technology has gotten, and it's continuing to get better and better. And here's another one. A lot of people were quite impressed by this, by the ability of artificial intelligence to appear essentially creative. And we're actually now looking at this from a software perspective, where this same types of prompts are able to generate entire 3-tiered web-based apps. You can actually generate software. We've gotten to the point where AI is, for certain types of tasks, is performing as though it is a skilled and a trained software developer. So you can just only imagine all the opportunities that exist. So this is ChatGPT. And ChatGPT played a big role. It's a type of algorithm that's based on something called the transformer architecture. And it played a big role in bringing generative AI to the surface. And that was, I believe, in November 2022, when OpenAI released it to the public, and it was the fastest growing app in history by a long shot, as people started to see the marvel of what AI technology is able to do. And I think that played a big role in bringing this to the mainstream. This is an experiment that I did when I went on ChatGPT then. That was 2 years ago now. And or about a year and a half, and I wanted to just see, it's easy to, when you are prompting with very, very broad and, vague things, there you can be impressed by the technology. But in our field of ophthalmology, where we're dealing with the eye, and within ophthalmology, we have 5 to 8 different subspecialties, and so clearly we're focusing on very, 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 very specialized parts of the body. In my case, I'm a retina specialist, and so I said, let me see what the knowledge base of the ChatGPT would be for some very, very basic retina type question, just to query it, because I would be able to easily find any loopholes. And so I asked it a very generic question. I said, how does one treat wet macular degeneration? And the response that it gave me was not unreasonable, right? It seemed you can in some respects, but by and large, largely accurate. So I felt that was quite interesting. And my next question for it was, what types of anti-VEGF medications are available in the US? And it gave me a response, then, which was interesting, but it had left out one drug at the time. It had left out Vabysmo, which is faricimab. And so I asked it. I said, so it told me Avastin, Lucentis, Eylea, and Beovu. And I said, what about Vabysmo? And it said, I don't know what that is. Does it go by another name? And I said, yes, it does. Vabysmo is faricimab. And so it gave me a response, and it said, yes, I know what that is, and it's in clinical trials at the moment, and so on and so forth. And so it gave me an answer that would have been accurate about a year before the time I was asking it the question. So that's quite interesting because that gave me some insight into the way the algorithm is trained. It was clearly trained at a certain snapshot in time on publicly available data, probably from the internet. Because at the time I was asking it this question, Vabysmo had completed their clinical trials and had gotten FDA approval and was already in use in clinics. But all said, it didn't leave me unimpressed. I clearly this is not a clinical tool by any stretch of the mind, but it's something that you can start to see the potential of where generative AI can go, given the vast amounts of information that we as a community of ophthalmologists have built up over the centuries, quite honestly, not just categorical factual knowledge, but also imaging, information, and data of various forms. So one of the big areas where medical AI has made impact, and really at this point for probably what's coming up on a decade now, has been making impact, is in the area of image recognition, and more broadly in the area of classification. And the classification problem, again, when you're building technology, one of the key things is always distilling it down to what the essentials are. So before we jump in and say we're ophthalmologists and we're looking at, say, glaucoma, or even just a basic question of screening, is this person a glaucoma risk or not? Before you even get into that, one of the important questions to ask is, what is the modality of the data that you're looking at, right? And if, for instance, it's imaging data, right, that is gotten from a picture, then the mathematics, the computer science of that question is essentially really the exact same mathematics as trying to tell a picture of a cat from a picture of a dog, right? And the ability to transfer the knowledge, the code base of those types of problems also enables us to be able to advance very quickly, because the same sets of algorithms and efforts and resources that are being put into a generic casting of a problem can automatically be deployed and utilized with some fine-tuning, of course, and with localization and specification, but can very quickly be deployed into multiple different arenas. And you can go up the root of the tree to different levels and apply that exact same principle. So here I've got a picture of a cat and a dog, and starting around the year 2010, something called a convolutional neural network started to win a lot of competitions. And that's when really the AI buzz really started to take off. And I had the privilege of being a part of seeing all of this from, in some respects, in terms of it becoming a true commercial grade technology that was recognized largely as something that will be revolutionary. I've had the privilege of being present during the course of that process, and initially as an observer, and then very quickly started to really make this a full-time thing that I do. I continue to see patients, as I mentioned earlier. I see retina patients as well as work on AI. I've been doing that since 2017. So that type of task is called image classification. And that is probably 50% or more, if not 80%, of the way that AI has been used. And the technology in particular is called a convolutional neural network. Example, something like this. Here's a picture, which is so all of us are, if you're not plastics, you might wonder, what this is, and and I'm certainly in the retina, we're not looking at that. So we're doing a lot of Avastin primarily. So here you've got this, and they say, if somebody asks you, what is this? Melanoma, squamous cell carcinoma, basal cell, or is it not cancer at all? This is the type of question that will be ripe for to train an AI algorithm to be able to answer. And I think a lot of us would have gotten this right, and a lot of us might not, because this is really not our field. But it's something that an AI might do might tell you that 90% chance this is squamous, right? So these convolutional neural networks, when they're trained, they really would just give you a set of percentages that will add up to 100%. So it's kind of telling you what is the weight, how confident is it that it's one of these things or the other. So in this case, it says 90% confident this is squamous cell carcinoma, okay? And quite easy to overlay a conversational chatbot on that. Now, here's another image. This one is, I think most of us are going to get this right. And if you said melanoma, you would be correct. And so your AI might say, because the AI would have been trained on lots and lots of images of melanomas and things that are not melanomas. And so when it sees a picture that it's never seen before, it takes that picture, any kind of data is just a bunch of numbers, right? So a picture is just a bunch of numbers on a grid. It takes that in, and then it passes it into a neural network, and it puts out an answer. All right. Similarly, something like a chest X-ray, not only might it be able to tell you what the diagnosis is, it can also tell you in another type of task that's called object detection. It can tell you where the issue is. So in this particular case, you can see here, there's the red circle, and it's telling you that something is up, something is not right about this image, and it is right there. And it tells you exactly what that is. A lung nodule. So this type of task is called object detection. Again, this is a generic task within the field of computer science. And as I mentioned, that's sort of the general principles are what does the world look like and what types of problems are the same. And then when you solve those problems, you can apply those solutions to different domain. And medicine is just one such domain. And then within your domain, of course, you then have to fine tune and you have to specialize and you have to validate. And the stakes are very high. So one word that I've mentioned a lot is the word neural network. So when you ask the question, how is AI built? And if you could only give one answer, your answer should be neural network. And that's going to be true for just about any AI system. The rest are details. Okay, this neural network is essentially the sort of the DNA of what an AI system is. It is the basic module of artificial intelligence. So here is a neural network, and how does it work? The way that it works really is you have a lot of data, and essentially all learning is supervised learning. The term unsupervised is a term that you might hear, but unsupervised learning doesn't really exist. So all learning is supervised, meaning that there has to be something that's guiding, that is serving as a reward mechanism to tell your algorithm when it's right versus when it's wrong. Whatever that thing is the teacher. It is the so-called loss function or the score function. Your algorithm has to be getting a score to tell it how it's doing, and then it adjusts itself to do the right thing. So here on the left, I have a series of retinal images of various forms, and they have some labels associated with them, right? Some might say normal, another one might say branch retinal vein occlusion, perhaps. And so these images are themselves numbers. Images are numbers. Basically, the black part here might be 0, and the lightest part on here might be the number 256, and all the other numbers in between them. And if you have 3 channels, red, blue, green, RGB, then you have that same scale, and that's how you get pictures like this. It's just a bunch of numbers. So you feed your numbers in on the left, and it converts them, and it does a bunch of things to them, mathematical operations, matrix multiplications, and spits them out on the right side. And depending on the number that it gives out, it's going to just put out one number for each image. If that number is the wrong number, right? Say there's a number for branch vein occlusion, and for this picture, it doesn't put out the right answer, then what's going to happen is you're going to penalize it, and it's going to go here and say wrong answer. So it's going to tell the algorithm that you didn't do well. So it's like, you can think of it as a Pavlovian experiment, almost like a little bit of an electric shock. And the algorithm says, ouch, I'm not going to do that again. Whatever I did, I'm going to do the opposite. And so this happens over and over. And if it gets it right, instead it gets rewarded. It's like a little bit of juice, orange juice. And so it says, wow, that was good. I want to do that again. And this happens thousands and thousands or millions of times until these numbers in between become smart. Now they actually know what the different diseases are. And you can give it now a picture that it's never seen before, and it'll get it right. That's the whole story. This is a neural network. I've not put up any equations, as I mentioned earlier. I've written a book about this with a lot of details, and those are in there. But that's the gist of how basically every AI algorithm works. in essence. Every AI algorithm, just about every AI algorithm really is made up of neural networks. And this is what a neural network is. Okay, so similarly, you could have, and this can be done for anything. I showed pictures of retina, but these are pictures of melanomas of various forms of, or rather, skin malignancies. And as long as the labeling is there, you can do that process and train your neural network. That's how it works. And I've put an equation here just to sort of give you a sense of, this is called stochastic gradient descent. And some of you might be data scientists or might be getting into some of that detail, and these terms would sound familiar, but really this is, the previous slide has essentially told you just about the whole story of what's going on. All right, so clearly one thing that I mentioned that's quite important is data. Data is so key for all of this. Where did you get the data? Is your data representative of the intended use population? How did you mitigate against data leak? How did you verify that mitigation? Did you train, test, separate your data? How did you verify that separation? So I mentioned that the core math is often the same across industries for problems. Problems are boiled down into sort of mathematical form. But the actual building of a product, especially within the field of medical devices and medical-based and grade software, and really any industry that you're going into, then there's specific customization. So in our particular case, clinical trials, right? So now you're dealing with people and you're dealing with actual data, and there's so much else that goes into that process for ensuring that, for validating your data, and for ensuring that it is safe and that it is transparent, for ensuring one thing that's very near and dear to our heart is demographic subgroups, right? Ensuring that your data works on everybody. That does your data work? How does your data do on African Americans? Okay. How does your data do on Asian females, right? How does your data do on Caucasians? How does your data do on people who are under the age of 40, for instance? All those things matter so much. And so you then have to look at that. And what is the intended use population? What's on your label? Who is this? Who are you building your device for? And who should it work on? And so all of the very, very critical and important questions, an enormous amount of resources and effort and time go into ensuring that all those things are done very, very meticulously. Very important. So one interesting question is AI actually having an impact in healthcare? Right? We've heard a lot of buzz, and we've been hearing buzz now for what's probably soon going to be coming up on 10 years. And it's probably going to be mixed. There's definitely impact. Is the impact happening? Is there untapped, unrealized potential yet? Absolutely. Is AI going to totally revolutionize healthcare in the fullness of time? Yes, absolutely. How fast are we getting there? Are we getting safe and effective products and solutions into patients' hands and changing their lives at the rate that we should? Probably not. Okay, but there is some progress that's been made, and one of the biggest areas where we will be seeing change, and we're starting to see change, is in the area of value-based care. And value-based care is really the idea of how can I provide better care for my patient, higher quality care, and give them a better experience at a lower cost. It's about efficiency and it's about efficacy. So high quality care, meaning better outcomes. I want my patient to do better. I want them to spend less, and I want them to have a better experience. All those things together. And that's where AI is going to shine the most, because it's a technological solution to several problems that are really, really difficult to otherwise solve. And so that's sort of the triple aim of value-based care. And I think that's where, in my view, that's where a lot of the progress will be seen. Breast cancer imaging, for instance, conditions that affect a large percentage of the population, to where if they're missed, it can be devastating, it can be fatal, it can be enormously costly, draining, and potentially bankrupting families. And there's not enough of that early detection going on. Those are areas that are ripe for AI. For instance, breast cancer screening, or even one solution that's already available is something called early notification for stroke. When a patient has a stroke and they go into the ED with symptoms of a stroke, they get a a CT scan done, and if there's a large vessel occlusion and symptoms began, less than 4 hours ago, they can get TPA in the neurointerventional suite. But time, the term that's used is time is brain. If time is wasted, they lose that window and they get poorer outcomes. This is an area where AI has been able to be put into the CT scan in the ED. And right from the ED, it can flag it before being read by a general radiologist. It can flag the neurointerventional radiologist, and they can get the suite ready for the patient and take them straight there. And the TPA is waiting, and they're able to increase the patient's chance of doing well. So that's another example of sort of where we're seeing. And again, the mathematics of this, convolutional neural networks. So this comes down to truly that cat versus dog problem. And the only differences are your data. How large is it? How good is it? How quality is it? And the extent of training and validation and quality control that you're doing. And that's a whole nother field. I chair the Summit on Medical Device Software. And so there's enormous amounts of regulatory control and standards around what need to be met by these types of products. So what does the future hold? The future is bright and it's wide open. As I mentioned, there's so many opportunities for this to be used, for this technology to be used. Here's a paper that I wrote in 2019. It's hard to believe that was almost 5 years ago. And this was the first instance of using generative adversarial networks to synthesize OCT images. This is the first time this was ever done. And I passed this around to a few of my colleagues, retina specialists, to see if they could tell which of these were synthetic data versus real data. And it was impressive. I was impressed to see that they couldn't tell the difference from the AI. So now this technology has clearly enormous amounts of potential that has yet been untapped for various utilities within ophthalmology. So this is just one example. This was from, believe it or not, this was from 2 years ago already. Time flies. And large language models have, ChatGPT is an example of a large language model. Google built a large language model to take the USMLE exam, and it scored 85% on it. I'm sure by now, easily, there are LLMs that are scoring 100% on the USMLE. So that's another example. In terms of the basic knowledge that we as humans memorize and are verbatim spitting back, the large language models can do much better in those things. So ultimately, it's going to be recognizing where it is that we as human expert doctors can appropriately leverage these technologies to improve the quality of care that we're able to deliver to our patients and reduce the cost and burden on the patient and on society. Another area, and I think this is probably one of the biggest areas, just from a practice perspective, is the area of electronic medical records. The next generation of electronic medical records will clearly be LLM based, and we haven't even seen the surface of that yet. So the best state-of-the-art electronic medical records today are barely tolerable. And I know a lot of physicians who have walked away from medicine and hung up their stethoscopes because of the burden of things like the EMR and prior auths and so on that we battle with, which have almost nothing to do with the direct patient care of caring for that patient that's in front of you. I think AI technology can really help break down a lot of those barriers, making it a much more joyful experience to practice medicine, where you can go in there and just focus on your patient and make sure they're getting the care that they need. Thank you very much. This truly has been an honor. And I love the National Medical Association and all that it represents. And I believe that with the leveraging of artificial intelligence technology, we can really improve access to care. That's what this is about. We can improve access to care, we can improve the patient experience, and we can ensure that regardless of a patient's ethnicity, race, or their socioeconomic status, you can get the best care possible to our patients. And that's what matters the most.
Okay. Thank you, Dr. Stephen Odaibo. That's a great presentation that you gave us here on AI. I took a couple of notes here just to make a couple of comments about the future of AI. Big data is very important, okay? Big data is very, very important. And to get big data, we're on the front line of healthcare disparities in our communities, and we're going to need bigger data from our patients that we serve to diversify the data mix in AI. And we'll need to partner with industry, because to get many images, whether it's retinal images, trabecular meshwork images, optic nerve images, we have to have manpower, investment, and time and energy with that. So we'll have to partner with industry to do this. The NMA is going to be an important part of doing this. Another example of getting more big data, AI can look at x-rays, and not only can it pick up a tumor from an x-ray, but it can tell by looking at the x-ray if the patient is African American or Caucasian. Okay, we don't even have the ability to do that as humans as of yet in many cases. Okay, and where is this data coming from? When we look at the globe, we have to make sure that this data is also coming from the African continent, from the Caribbean continent, Indian continent, Asian continent. So globally, we have to make sure that everybody's involved and participating in this. And it's going to improve the high quality care, lower cost, to make care more affordable, more accessible to information to patients in that respects. And like I said, some of the Chat GPT programs, about 23% of Americans have used it. And that number needs to go up. And this is part of our efforts to help educate the community, educate doctors, educate patients, educate families to learn about this, to embrace this technology, to get more information. So once again, thank you, Stephen, for that excellent presentation. We appreciate that. You're here in spirit with us. I know you're busy and couldn't make it with us live, but thank you so much. Next, I'm going to introduce our next presenter who's going to be live, Dr. Renee Boville, who is the founder and medical director of Advanced Eyecare Medical Center, PA, DBA Envision Eye and Laser Center. She is a board-certified ophthalmologist, was trained at Wellesley College, UCLA School of Medicine, Yale University, and LSU Eye Center. Additionally, Dr. Boville earned a master's in cybersecurity strategy and information management from GW, focused on policies and practices that protect critical information with particular attention to the healthcare field. She has an academic appointment at Howard University Hospital, Ross University School of Medicine, and University of Maryland Capital Region Center. She is the current president-elect of Ophthalmology World Leaders, and it's a pleasure to bring Dr. Boville on board. Can you bring Dr. Boville on the screen, please? Thank you for joining us, Dr. Boville.
Thank you, Dr. Laroche, for that warm welcome. And that previous presentation by Dr. Odaibo was very exciting and informative. And I look forward to delving into some other aspects of artificial intelligence.
Great. Thanks for joining us. And I'm going to turn it over to you, and we can just get into it, and we'll talk a little bit later on. But for those in the audience, please like and share the video. Please type your questions in the chat. We'll put on a link at the end of our presentation if you want to come live. And I'll turn it over to you, Dr. Boville. Thank you so much.
Okay. And I'm going to ask for some assistance from our brother Mabry, our IT specialist here. Good. Okay, so now I will start my presentation here. I hope everyone can see my presentation. Can you hear me?
Yes, I can hear you.
Dr. Roche? Okay, so I'm going to talk about AI and focus in on ophthalmology and how we can transform eye care with artificial intelligence. Okay, okay. I think I have a little bit of delay. So some of the benefits of AI, as Dr. Odaibo mentioned in ophthalmology, are efficiency. We can streamline workflows, reduce manual tasks. We can certainly make things more accurate and enhance diagnostic precision, and we can improve accessibility, especially in remote areas. Now, first, I'd like to start by talking about what are some of the challenges faced by medical practices. Even our patients probably are affected by some of these challenges. We have staffing limitations. It's harder and harder to find staff. Some people may want to work from home, and in our field, we can't work from home. There are time constraints, efficiency issues, and certainly costs. So let's see how AI can help with that on the administrative end. Well, we talked that it can eliminate repetitive tasks, and that allows for more time for us to focus on patient-centric tasks, such as actually talking with the patient, so we can reduce our administrative burden. We can make patients happier. And then on the practice side, that allows us to look at patient behavior. Which patients tend to have no-show? Are they no-shows more in the afternoon, more in the evening? And then we can adjust and make changes and perhaps decrease wait times. There are AI software out there now to automate appointment reminders, 24/7 call handling. Now it's difficult. Many of us work 9 to 5, and maybe it's difficult to make calls. AI can help with that. So how is this done? Well, we use data analysis and use AI to analyze patient data, and then we can identify certain trends, improve care. We can use virtual assistants, AI chatbots, so that even if we are not in the office, the chatbot can help patients make appointments, answer questions. We can use automated check-in systems, and some of you may have used that already, may have noticed that in certain offices. And definitely AI can be used in billing and patient record management. Consensus is a cloud solution software that is using AI in prior authorizations. We all know that is definitely a burden. It takes a lot of time, and you can use a software program like this to help with your prior authorizations to make sure that, number one, it's right. Look at your insurance package and see, does it even truly really need a prior auth? That way, if it does, the software can go ahead and get started. If it doesn't, it can go ahead and you can go ahead and schedule the patient. Additionally, I'd like to point out that when choosing a software, you do want to make sure that it is HIPAA compliant. And here, I don't know if you can see it says it's HIPAA compliant. So it has HIPAA compliant signatures. That lets you know that this is something that is going to help enhance instead of put you at risk. Next, there are other softwares such as Oracle, and you can see they can help in clinical applications, in financial, population health, enterprise, and also for the consumer. And what a lot of these systems do is they actually work in conjunction with your EHR and with your practice management system to help enhance. It's like having another layer, another helper on top of what you already have. Again, this is another software, and these, I'd like to point out, are already in practice. So we can already do this right now. Help with registration and intake, help with scheduling, help again with prior authorizations. I think this is very exciting. And again, there are AIs that are put on top of your EHR. So you can just talk naturally, and it is able to gather the information, and then it's able to put it exactly where it's supposed to be in the SOAP note format or whatever format you use, and place it there. So that saves a lot of time, so that you as the physician are not staying after hours for a long time. Now, with any kind of computer work, I would say don't just blindly trust it. You should look over the note just to make sure everything's okay. But this is something that is helpful. And the way this is done, a lot of times it's not 100% done by the computer. The computer takes everything in, and then there are scribes on the back end that look and make sure everything is going in its proper place. I'd next like to talk about how this is something that's near and dear to Dr. Laroche's heart, glaucoma. So how can we use AI in glaucoma? Well, this was a paper that was just published this year in January, and it showed that predictive models can be made stronger with AI. And what this paper showed is that you can look and identify a patient's risk for speed of disease progression, and you can do this by inputting the patient's genetic makeup, look at historical IOP trends, and in imaging data, put that information into machine learning techniques which is AI, and it will let you know, is this patient at high risk, medium risk, low risk? So this is something that I think is going to be really revolutionary in glaucoma. So how is that done? How we talked earlier about how AI looks at images, sort of gets a feel for things, and then is able to look at a new image and then be able to say, all right, this looks like glaucoma, this looks like mild, this looks like moderate, this is not glaucoma. So what are the steps involved in AI measurement of cup to disc ratio? Well, first, we have to acquire the image. Then there is the pre-processing of the data, and then you have to segment the data. So what are you doing with segmentation? Well, if you look at this first picture here, you see first it outlines, you see these dots, it outlines the optic disc. Then it outlines the cup. Then you have to look at the diameter, and then you have to, the diameter of each one, and then you have to make a ratio calculation. So let's look closer and see what that actually looks like. This is the first step. Next, this is another paper that was put out last year. And what they did is they actually had several experts, 5 experts, look at optic nerves. And you can see first each expert looked at the optic nerve. Then the way computers read, they don't read in the colors like this. Computers that we have now work on a binary system. So either it's a yes or no, either it's on or off, a 1 or a 0. So the way we do that is in imaging is we make it black or white. So you can see the shape. So it outlines the shape, and you can see each expert outlined the shape. And then each expert outlined the optic disc, the optic cup. And then here you can see that. And then what happens is, lastly, it combines it and it shows, okay, is this glaucoma? Is this not glaucoma? So I think this is a very good example, simplistic example, to help people understand how AI actually goes through and makes the decisions. Now, we talked a little bit about retina. Let's talk more about retina using diabetic retinopathy in actual practice. And I'm going to talk about two systems that are in practice right now. IDX-DR is the first FDA cleared autonomous AI system. So that means there was no physician oversight. This software is made to be used in a primary care setting. This is something where AI can help in more rural areas. And the main thing is they want to determine whether a patient needs immediate follow-up. And what the way this software works is, you can see in the picture, this is in a primary care setting. It's able to take a picture, it's analyzed, and then it gives you an answer. Does this patient have diabetic retinopathy or does it not? It only answers yes or no. If it does, then what happens? The patient is referred. And it saves the patient time because they go to their primary care doctor and they can be referred right away if necessary. And it's showing that it was able to diagnose 96% in a large diverse population. So only 4% of the time did the AI say, I don't know if this person has diabetic retinopathy or not. Next, this is another software, iArt, and this was cleared for detection of more than mild and visually threatening diabetic retinopathy. It can also detect clinically significant macular edema. Now, I want you to understand, AI does very specific tasks. That first one was answering, do you have diabetic retinopathy or not? This next iteration or next software is looking for more than mild and also vision threatening, and it can detect CSME. So it was tested on more than 500,000 patients, nearly 2 million retinal images globally. And again, it's done during the diabetic patient's regular eye exam. And this is really, really interesting. I want you to remember back to your statistics: high sensitivity equals safety, high specificity equals effectiveness. So it showed a high sensitivity. So 96% for more than mild diabetic retinopathy, 97% for vision threatening, and the specificity was 88% for more than mild and 90% for vision threatening. So this was done in a multi-center trial. So this is something that really can be very effective and help patients who might not be able to get to a retina specialist. And this is what iArt spits out. And even if you can't see everything, you can see, okay, green for diabetic retinopathy here, they're saying it's negative for more than mild in both eyes, retest in 12 months. So that patient is safe. Maybe you want to see them back in a year. The other patient, red. Okay, that's a problem. Vision threatening diabetic retinopathy in each eye, and you have to refer them to a ophthalmologist, hopefully a retina specialist, for further treatment. Now, it's important to recognize this is great for diabetic retinopathy, but what did we talk about just prior to that? Glaucoma. So these patients who are being screened by iArt or IDX, DR, are not going to be screened for diabetic retinopathy. So it's important to realize, why do you still need the physician? Because as we are looking at the patient, we're also looking for other diseases, not just one. So just remember, AI only screens for one thing at a time, exactly what it was trained to do. But there are things that it can do way better than what a human can do. So looking at retina images from fundus images, AI can predict cardiovascular risk factors. This was from a paper in 2018, and it looked at retinal images, looked at optic disc or blood vessels. I have that picture in the background because to me, this is mind-blowing. So it was able to determine age within 3 years, gender with 97% accuracy, even your systolic blood pressure within 11 points, and whether or not you've had a major cardiac event, and even the smoking status with 71% accuracy. So this is to me, as I said, it's mind-blowing. These are things that a person cannot do. Using this kind of data can really revolutionize how we treat people and how we're able to develop new kinds of screening methodologies as well. AI is also being used for neurodegenerative diseases using OCTA. Now, the OCTA is a very specific kind of scan, and it kind of combines looking at an OCT, and it looks at blood vessels. So it combines that along with an FA. This is great because in years ago, when I'm speaking to the patients here, we had to inject fluorescein into your arm. It was a little more invasive. Then we had to take pictures, serial pictures, and look at the retina and see the fluorescein going through the blood vessels. Now we're able to do that just with a non-invasive scan. Now, the OCTA may not be quite as accurate in certain areas, and some retina specialists, I'm sure, prefer the FA because they may feel that they have more control. But in 2023, this paper was published, and they were able to show that they're able to determine if a patient has Alzheimer's disease or is at risk for Alzheimer's disease, Parkinson's disease, if they have mild cognitive impairment or not. So we're looking to see if we can start using this kind of data and determine earlier and earlier and earlier what kind of diseases patients have, way before they're shown in the brain, the amyloid deposits show in the brain. So again, once this is really ready, this will be revolutionary because we'll be able to treat all of these neurodegenerative diseases earlier. And the reason why we're able to do this with looking at the eye is the retina folks know this, but the patients may not know. The retina is actually an extension of the brain. So that's how this software and diagnostic tool works. And I'd like to say that this AI, it's a tool. It's not something that 100% you look at this and you forget about everything else. No, it's a tool, just like spell check is a tool, because we all know sometimes we're typing along and spell check will, I use it often, and if I'm writing something about EHR, electronic health records, it changes it to her, HER. I don't mean her, I mean EHR. So spell check is a tool, but we have to be in control of it. So there's another paper that was put out in 2022. This is again looking at beta amyloid in the brain and cognitive decline in patients with Alzheimer's disease. And again, it was very, very effective at being able to predict and determine if a patient has cognitive decline. And using that, we're able to get these patients treated a lot earlier. So you may say, how else? We know that it can be used for diagnostics. We know that it can be used certainly for mundane, some of the tasks we don't enjoy, such as billing, prior authorizations, but it also can be used for patient education. How is that? Well, it can generate video ideas. It can write detailed scripts. You can use audio and video output. Earlier, Dr. Laroche mentioned ChatGPT, which is very effective in doing this. There are other ones such as Copilot and Claude that can help create videos and make it easier for the patient to understand. And the way you can do that, and what I like to do, is when you are using ChatGPT, if you want to create a script, you can say, make this explain glaucoma to a patient, and then you can look at it. Or you could say, talk about glaucoma to a professional group of ophthalmologists, and it will use more medical terms. So you have to, again, it's a tool, so you have to direct it to do exactly what you want it to do. And I will say with ChatGPT, you do have to be careful. Just because it prints it out, it can make mistakes. I think Dr. Odaibo mentioned that earlier. Or it may say, I don't know. Right now, ChatGPT, I believe, is updated up until last year, April of 2023. So if something has come out since then, it's not going to know that. So now I'd like to talk about how, I'm mostly talking about physicians, but anyone, how do you know what to look for and what software to choose? Well, you want to look at software and ask them if they have the expertise and experience for what you need. If you're in ophthalmology, for an ophthalmology. You want to know what kind of technology do they use. I mentioned earlier, HIPAA. How do they handle data and privacy? What's their model? How do they customize? Because you don't want someone just to say, here, use this, and they throw the box at you, and then it's done. And we know that has happened to us, especially in ophthalmology with our EHRs. A company will say, hey, use this EHR, and it was an EHR that was developed for primary care, and they don't know what words we use, what lingo we use in ophthalmology. So you want to make sure that it's customized to you, and that hopefully that they're doing a lot of the customization, and you don't have to take your time to do a lot of it. And of course, you want to look at their customer support, how they're going to help implement, um, and then of course pricing and contractual agreements is how often do you pay? Do you have to pay for updates or updates included? Things like that. And I've already mentioned some of the limitations of AI tools, but there may be training complications. I think Dr. Odaibo mentioned that we want to make sure that the training of the AI that you use, the pictures, the images are diverse and representative. So if I have an AI and I'm only using men, and then I show it a picture of a woman, it may not know or understand what to do. You also want to make sure that the people who are developing the AI are diverse as well. Why is that? Because diversity equals diversity of thought. There's also always an increased security risk whenever you put any kind of data on the internet. It's just risky, but we have to make sure things are safe, and there are ways to do that. Maybe next time we can talk more about cybersecurity and how that can happen. And you want to make sure that it's used ethically, that other people aren't benefiting and the patients are not benefiting. The government is working on this. Last October, the president put out an executive order on this safe, secure, trustworthy use of AI, and trying to increase it and strengthen AI governance, advancing responsible innovation, and managing risks. So we want to make sure that we benefit from AI instead of just becoming lazy thinkers. AI should encourage us to think more, not just strictly rely on it and not be in charge of it. So I think that the name, and others think the name, instead of artificial intelligence, it could be augmented intelligence. And we know that no software is infallible. And again, remember that it's still very important for physicians to be involved, because even with these FDA approved algorithms, the software is choosing between whether or not the patient has diabetic retinopathy or not. That is it. And it's something that we can use, and that's going to be very, very helpful for us. But if we use data sets that are narrow, meaning not wide, not diverse, that can make racial disparities worse. It can lead to more marginalization. And so it's important to look and see what these data sets were trained on. And I mentioned the AI creators themselves need to be diverse, as well as the developers of the machine learning models. The AI should strive to access training sets from diverse organizations. So that means the NMA is important, NAACP. We all want to make sure that we are part of the data sets, just like we should be part of clinical trials as well. Will AI take over? Absolutely not. I mentioned over and over again, your physician is still needed. AI systems only are looking at the diseases that they are trained for. And I'd like to say thank you so much for your attention. And that beautiful eye was made by AI. I asked an AI tool to make me a colorful eye with brown skin, and this is what it came up with, and I thought that was wonderful. Thank you all very much. Okay, Dr. Laroche, are there any questions? I tried to make that 20 minutes. Is Dr. LaRoche there? Oh, Dr. Odaibo is there.
Yes, wonderful talk.
Oh,
Thank you so much. I really enjoyed it.
and I enjoyed yours as well.
Thank you.
And, you know, I have to say, I don't know if Dr. LaRoche is on, but I think it is fantastic that we have physicians like you that are really involved in the forefront of developing, because I just talked about making sure who is developing this, because I know you're going to make sure that, you know, you're looking at retinas that look like my retinas.
You
And
bet.
that is extremely important. And that's actually why I got involved. I came into AI through cybersecurity. So that's really what I am excited about, keeping data safe. But even as physicians, if physicians are not involved in all aspects of this, we're just going to be thrown something at us and here, use it, and it's going to be so hard to use. I remember the first EHR I used. I guess I should not say the name, but it was made for primary care, and I looked at the language, and it said the cornea is shiny.
Dr. Boville, thank you for your excellent presentation.
So we can't have that happen with AI, please. So continue what you're doing, Dr. Odaibo.
Thank you. And you too, Dr. Boville. Excellent point. It's so critical. Representation, really, lived experiences matter so much because that's what informs what you put your effort and your focus on. And I think that it's really a critical point that you made. I was nodding vigorously as you were talking.
Thank you both again for your outstanding presentations and your work you're doing in this area. I have a question for the both of you. In your personal lives, how do you use AI? And in your medical practices, a lot of programs and things were discussed. How do you personally use AI, if so, in your medical practice at all? We'll start out with Stephen real quick.
Yeah, you know, I really believe that the usage of AI and staying on top of all the different tools and things that are coming out is a field on itself. It's a specialization unto itself. And it's something that personally, it's not where my focus has been primarily. I know several people that are that know, you know, all the different combinations and iterations of tools as they emerge and as that proceeds. But from my perspective, I've been, you know, sort of focused very heavily in the last 2 or 3 years on the back end, on the development side, doing clinical trials and the like, and trying to get some of these products out. And so I think probably Dr. Boville might be able to speak, because I really enjoyed your talk and all the various points that you brought up with respect to how large language models, ChatGPT, et cetera, could be used clinically. And also, I think I'm probably somewhat precluded from discussing some of the details with respect to products that are competitive with ours that might already be on the market.
Okay, thank you, Stephen. Dr. Boville?
Yes. So I use AI, pretty much ChatGPT. I use what else did I mention? Copilot. I like that. There's Dolly. I use that. I think that's the one I used to create that eye, and it's I mean, it's really kind of fun. in when you're giving presentations and things like that, getting a template, getting ideas, and it really helps. In my practice, I haven't started. I'm not on the cutting edge in the practice yet. Waiting a little bit. I'm more erring on the cybersecurity side because I don't want to put the data out there just yet. But I am really looking forward to having it help with, not with clinical yet for me, but with prior auths, things like that on the admin side to take a lot of the burden off of the front desk and the back office. Now, I do know up at Temple, they're using, I can't remember which one they're using. I don't know if it's IDX or iNook, but they are using that in practice. They have that in their primary care offices, and then that helps them screen a larger number of patients. Because we know it's easy for us to, the primary care doctors, to say, hey, look and go get screened. But I wonder, and Dr. Odaibo, you probably know, how many of those patients who get that appointment to go see the ophthalmologist from the primary care doctor actually go, right? Not
Right.
that many. But if and you know, I don't want to, you know, I don't know where you are with your your Retina AI health, but just imagine if we had that in a primary care office, and that software is able to say, you have diabetic retinopathy, or you have this. That patient is going to be much more motivated to say, okay, let me go see a doctor because I already know I have a problem.
Absolutely. There's a huge gap in terms of the percentage of patients who are diabetic and who should be getting annual screening and those that are actually getting it. So in 2009, Benoit et al. Published a paper which was based on Medicare claims data. So we're actually even talking about insured patients in the US, because that's the data that was available. Of those, they found out that only 15% of patients within a 5-year gap met their screening guidelines.
Oh
And
my gosh.
yes. And in the last year, there were only 50% of patients did not in the year before they had that data collected. So that's a massive gap. And for various reasons, you know, in the chain, there's many places where people can fall off.
You know, it's interesting because I've received phone calls from primary care doctors who have asked me about some of these AI diabetic screening retinal tools to place in their offices. And I had a little bit mixed feedback in terms of that. Because one of the things is, oh, you have this tool that's in the office that screens for retinopathy. And sometimes you can say to the patient, oh, you don't have any diabetic retinopathy, you're okay. But do we miss the opportunity? Because I know in my office, when I have a diabetic patient, and although they may not have retinopathy, I still do spend some extra time to talk to them about the diet, the exercise, to help preserve the vision, to preserve the vascular flow in the eye, and to prevent complications. And, you know, exercising, you know, walking 10,000 steps a day, staying away from rice and bread, eating more salads and vegetables. So do we run the risk of, you know, just to cut down on time and to be more efficient, just counting on the image and say, oh, you're okay, we'll see you later, and we're not focusing on some of the other things to keep the patients healthy?
That's exactly what I was saying. The AI, it's trained only for one thing, yes or no for a specific task. So we may miss glaucoma, right? We may miss hypertensive retinopathy, right? You know, cornea diseases, keratoconus. There's lots of things that we may miss by not looking. But and what I'm envisioning is that we're not going to have AI, you know, just for retina, just for diabetic retinopathy. But maybe we'll have a tool for diabetic retinopathy, another one for glaucoma, another one for hypertensive, another one for keratoconus, things like that, and then go that way. Now, the other thing, I was trying to keep the talk, but there's another software out there, or they're looking at visual fields. As we know, I know Dr. Laroche, it's way easier for him to interpret than it is for me because he's fellowship trained. But even sometimes, you get that visual field, it's all black except for a little bit in the center. Well, there's AI that looks at that central visual field and can determine what's going on. Is it progressing? Is it not? Where is it? So I think using AI to look at, and visual field is all numbered data anyway, right? So it's a lot easier for AI to look at that. So you may have to expand your name, Dr. Odaibo.
Yeah, like you said,
retina AI.
yeah, we might. Like you said in your talk, you pointed out some very, very interesting use cases that we've been interested in for a very long time, like cardiovascular risk, neurodegenerative diseases like Alzheimer's, etc. And the beauty of this is that implementation-wise, it's the same camera by and large. You can have a camera in a primary care doctor's office, and the rest of it is really software on the back end. Of course, one has to train it, you have to get the data, you have to do large clinical trials and validate it and so on. But from a hardware perspective, you have a single camera in a primary care doctor's office, and you just have to do a software update on the back end. And that's a new product, that's a new indication.
But I do think that Dr. Laroche had, reiterated kind of what I said. We're not going anywhere. AI is not going to take over our jobs because the touch point is really, really important.
So, Stephen, your company is called Retina AI.
Yes.
From a glaucoma perspective, the retinal ganglion cells are part of the retina.
You got it.
But that's
almost a retinal disease.
But that's like the end stage, though. The initial action in glaucoma takes place at the trabecular meshwork, where you have obstruction of the trabecular meshwork leading to elevated eye pressure. So I'm still working to try to get those tens of thousands of images of trabecular meshwork to further analyze that for AI. So that's a project I still have in the back of my mind that I'm working on.
All right. Well, listen, I gotta throw my thing in there. If you don't have a nice clear cornea, you're not going to get good images. Okay, so it starts with the cornea.
This is true. But remember the cornea is shiny. So if it's too shiny, that's going to be a problem.
So listen, you guys have given some excellent presentations on AI. I really want to thank the both of you. AI is here to stay. We have to embrace it. Only 23% of Americans have used ChatGPT. So there's much more room to educate our colleagues, our patients, the community about learning more about AI. This is a nice introductory video that we've done here. So at this point, we're going to bring it to a close. And in bringing it to a close, I want to give each one of you the opportunity to give closing remarks and let the audience know how they can get in touch with you if they want to follow up. And I want to remind the audience as well, and there are going to be many people watching a replay of this. As you're watching the replay, please like it to support the algorithm. Please share it with the community, your social media groups, to educate our community about AI. And please subscribe to our channel so you'll get more information about hot topics in medicine, hot topics affecting the eye, hot topics affecting our community. So I'm going to go over to Dr. Boville first for the closing remarks and any comments you want to say. Go ahead, Dr. Boville.
Okay. Dr. Laroche, this has been enlightening for me. I commend you for starting this channel. I think it is fantastic. And I'm also, like I said, on staff at Howard. I can be reached there. I love all things AI, all things cybersecurity. It's really interesting. And remember, AI, cyber, it's all a tool. We are in charge. And lastly, go vote.
Okay, thank you, Dr. Boville and Dr. Odaibo.
Yes, thank you so much, Dr. Laroche, for the opportunity, and Dr. Boville, thank you for everything that you've been doing in cybersecurity and AI, and for an excellent talk as well. From my perspective, what I want to say in closing is that it's really echoing something that Dr. Boville mentioned, is that it's really is critical and essential that there is representation of thought, diversity of thought within the manufacturing sector for medical devices as pertains to AI within healthcare. Martin Luther King said that of all the injustices that there are, healthcare inequity and difficulties within access in healthcare are the worst form of injustice that there is. And AI is such a revolutionary technology that's really changing everything. And so that's really an inflection point. And it's an inflection point that needs to be guarded, very closely in terms of ensuring that the technologies that will be determining the health and the well-being of humans and the ability for humans to reach their full potential is something that has to be done in a way that is equitable, that is just, that is representative of the population, and that is of the highest possible quality and the highest possible standards. And so you all know this, I'm sort of preaching to the choir, but it's very essential that we all ensure that this is done in the right way, and that people that need to have access to bring new products onto the market that are innovative and revolutionary are able to do that in a way that benefits all of humanity.
Okay, thank you both very much. We're at about the 1 hour 30 mark. So once again, thank you all. We're going to close it out. I'll ask you two to just stay on board for a second. Brother Reggie, can you please end the show? We appreciate you. Thank you.